Hello everyone, this presentation will be on feed intolerance and a little bit about necrotizing enterocolitis. Feed intolerance is something what we commonly encounter in our NICU, and it is not discussed in detail in one particular book as such, but new guidelines have come out. And as an extension of feed intolerance, I put a few slides on necrotizing enterocolitis because it is the most important surgical emergency what we deal with in the NICU. By definition, feed intolerance is defined as a difficulty to digest enteral feeds, and it's usually accompanied by an increase in the gastric residuals, that is aspirates, with an abdominal distension and or with the presence of a reflux. We commonly see it in preterm infants, and usually it results in feeding disruptions which ultimately result in a longer NICU stay. So if you consider an IAP definition, it is defined as the inability to digest enteral feeds with a residual volume of more than 50% along with the distension or emesis as both. So in this IAP definition, this 50% is important, where the residual volume is taken into consideration. Now most of the time it is considered as a benign condition, most commonly due to the immaturity of the GI tract and the inability to distinguish between ileus manifestations along with other NEC in the earlier forms of stage 1 is a common difficulty what we face practically. So if we classify the signs and symptoms, a common symptom of vomiting could be associated with an altered milk with bile or with a fresh blood stain, whereas signs include distension with an increase in the abdominal girth by more than 2 centimeters, presence of tenderness, a residual volume of more than 50% or 2 ml per kg, a reduced or an absent bowel sound, and or the presence of systemic signs like cyanosis, bradycardia, apnea and shock. Of course, more severe, more seen in severe forms of NEC. So coming to feed intolerance per se, the causes include a lower intestinal motility because of prematurity, deficient enzymatic digestion, inadequate bacterial colonization due to the deficiency of probiotic good bacteria, decreased hormonal response as well as local immunity. Now, like I mentioned about the clinical signs of feed intolerance, just to re-emphasize upon these, vomiting, abdominal distension, bilious gastric residues and an increase in apneic episodes, all of these are clinical signs with which we should predict and anticipate feed intolerance. To prevent feed intolerance, encouraging 100% breastfeeding is something which most units do, and it is one of the first and important steps towards prevention. And the second one is gradual escalation of feeds, generally when we deal with preterms to the tune of 10 to 20 ml per kg per day, never more than that. Now coming to the differential diagnosis of feed intolerance, we will go systematically. So physiological feed intolerance is seen if there is a hemodynamically stable neonate where all the other investigations are normal. If physiological time is the only healer and you gradually re-establish feeds, it will go well. If there is a sepsis component, the features will include a paralytic ileus along with abdominal wall erythema and tenderness. NEC, of course, being the most common surgical emergency, will have distension, emesis, apnea, hemodynamic instability, some amount of electrolyte imbalance, thrombocytopenia and classical abdominal X-ray findings with portal gas. Now if you have a spontaneous perforation and NEC might be mimics of each other, but X-ray showing a gasless abdomen with or without a asymptomatic pneumoperitoneum with some amount of NEC overlap features and a bluish grey discoloration of the abdomen, we can think in terms of a perforation. GERD will have a chronic weight gain deficiency where the baby is not gaining weight well, multiple apneic episodes, maybe some amount of desaturations and irritability. Metabolic causes like galactosemia being the most common, endocrine causes like hypothyroidism being the most common. And though when we think of surgical causes, we think only in terms of NEC, other surgical causes like obstruction, malrotation, perforation and intussusception also can cause feed intolerance. Allergic colitis will have a well-looking baby with some amount of distension and bloody stools. So bloody stools being pathognomic there. And infectious enterocolitis because of loose stools, most commonly due to viral etiology, bacterial also may be seen. Like I mentioned earlier, when we see the quality of the gastric residues, pure green color should not be only indicator to slow down. The color coding will come to it a bit later. But otherwise, if it is hemorrhagic, it is a more cause of concern. Now some controversy is there with respect to the refeeding of the residues what comes, but this evidence is more seen in adults, not so much in newborn. Common concern what we do see, of course, is because of the CPAP belly. So the CPAP, of course, being a primary respiratory support what we use, CPAP belly also will result in some amount of distension. It often gives a diagnostic dilemma whether we should slow down feeds or continue. But CPAP belly being a minor risk factor for NEC in some studies, but as a whole saying no risk factor. A simple maneuver such as putting a prone position and evacuation of the air before the feed will ensure that it doesn't ensure the slowdown of the feeds. Glycerin suppositories as such have no major benefit, and mere small amounts of vomiting alone is not a main responsive factor towards stopping a feed. Instead, however, if it is a bile stained or a blood stained vomit, we should investigate, otherwise it can merely be attributed to poor motility. And unlike the classical concept of GRD associated with apnea, there is no temporal relationship as per most recent evidence. Now, coming to the lab markers, of course, though it is more of a clinical entity, feed intolerance, few markers such as persistent acidosis, decreasing platelet count, leukopenia, and electrolyte imbalances, and poorly maintained sugars are early predictors towards developing NEC, but are not prognostic as such. Stool occult blood is, of course, one of the clinical tests what we do if we are suspecting NEC or suspecting a surgical pathology. And on an abdominal X-ray, pneumatosis intestinalis is being the most specific radiographic finding for NEC, the most classical finding. Now, between X-ray and ultrasound, it is again debatable about whether which is a gold standard, but recent evidence suggests that NEC is earlier picked up in ultrasound than in X-ray, with the findings being increased gut wall thickening, abnormal echogenic patterns in the bowel wall, increased vascularity, rarely the presence of free fluid, and of course the classical findings of portal venous gas and the pneumatosis intestinalis getting picked up. Of course, Doppler changes being an indication for early preterm labor and preterm terminations. Babies with Doppler changes are more prone towards feed intolerance due to the compromise of the SMA, that is the superior mesenteric vessels. As much as the statistical evidence of this is debatable, in clinical practice, of course, we do say that if there is an absent or a reverse end-diastolic flow, it is a risk factor towards feed intolerance, and almost all units in such babies go for a gradual escalation of feeds. Now, coming to the color coding, this is rather significant because we can use this as a test in the day-to-day practice. If you have a milk color aspirate or a lemon color aspirate, generally you can take these as just normal physiological intolerance and nothing major to worry about. You can just continue feeds, maybe a little more slowly. Now, the middle section is where the controversy comes. Somewhat darker yellow mustard aspirates or wasabi colored or lime color undoubtedly need a little more caution and can be brushed aside. At the same time, it doesn't need a full detailed workup. So the basic indices to rule out other surgical pathologies in NEC, if the level 1 workup is fine, we can continue feeds in a slightly slower manner. So maybe instead of 20 ml per kg per day, we can step down to maybe 10 ml and then continue increasing feeds or maintain status quo, but as such, no indication to keep the baby NPO with the middle segment. Now, the tricky part comes with the final part. If you have a dark green avocado shade or a spinach colored aspirates, it is almost always pathognomic of NEC, and the first step before doing anything further is stop all feeds, switch the baby to NPO and switch to maintenance fluids. Now, coming to some of the recent IAP 2022 recommendations, the best choice of milk available is of course mother's own milk. If unavailable, pasteurized donor human milk and then only formula. Trophic feeds should be ideally started within the first 24 hours of life. Once a baby is hemodynamically stable, evidence suggests that early starting of trophic feeds allows early full feed, which allows early discharge. Colostrum swabs may be considered if a full feed is contraindicated, mainly due to the immunogenic benefits. Of course, feed volume ideally should be increased at the rate of 10 to 20 ml per kg in preterm and very low birth weight babies, so there's no changes in that. Routine abdominal girth monitoring is not recommended unless there is a clinical sign of feed intolerance. As far as a tube feed is concerned, intragastric is preferred over transpyloric route, no doubt. And while choosing between OG and an NG feed, OG tube is undoubtedly preferred. Now, This is another tricky thing because some units prefer a continuous infusion feeds over intermittent bolus feeds for the reason of continuous weight gain. Now, as far as that is concerned, intermittent feeding is undoubtedly more physiological and is preferred, and continuous infusion feeds is recommended only and only if there is inadequate evidence of weight gain, baby is stable, and under special circumstances only. As far as second hourly versus third hourly feeds, it's more of a unit protocol, but it is preferred that very low birth weight babies, that is less than 1 kg, extreme low birth weight, should be fed every 2 hourly strictly, and slightly bigger babies can be considered every 2 or 3 hourly because they have some amount of metabolic reserve also. So as far as feeding in a SGA or in a condition where you are having an absent end diastolic flow less than 29 weeks and or less than 1 kg, we should increase the duration of enteral nutrition and go for a slower advancement as advised, because these are relatively at higher risk. Now HMF is again controversial with respect to feed intolerance, because previous few studies and articles do say HMF do increase the risk of intolerance, but at the same time it does give a nutritional benefit, nutritional fortification to ensure that the gut is mature enough. We can add generally HMF if we have reached 50 to 80 ml per kg feeds. This is one, and I think the key thing here as far as HMF is concerned is individual fortification. So by going for individual fortification, we can ensure that the overall balance is maintained and routine DHA supplementation is no longer recommended. Vitamin A is also not routinely recommended anymore. The old concept is now gone, but iron is recommended from the 2 to 4 weeks of life onwards up to the first 1 year because of the risk of physiological anemia. So that doesn't change. Iron is no longer considered as a risk factor for feed intolerance. Now as far as probiotics is concerned, many units do recommend a probiotic containing bifidobacterium species up to 36 weeks in extreme preterms, because it reduces, studies have clear-cut proven even as per the latest Cochrane reviews that there is a minimal risk of NEC, or rather we are minimizing the risk by this intervention. And vitamin D routine supplementation as per protocol is done with 400 international units per day. So if we do consider a full-fledged algorithm, if we are seeing a increase in the abdominal girth by 2 centimeters or more with vomiting, with the presence of aspirates, we'll assess whether the aspirates are clear or bile tinged. If you're having clear aspirates less than 25% of the feed volume, just look for a local cause and continue feeds. 25 to 50% reduce the volume but continue the feeds anyway, and more than 50% we should withhold the feed. Now from there, if we continue and the feed intolerance does recur, clinically assess the stability. If there is no systemic signs and clinically stable, of course, just check the tube position and withhold feeds temporarily for 12 hours, reassess and then maybe restart. If systemic signs are there, of course, then we'll go for the other causes. At the outset itself, if we are having bile tinge or blood stained, then we withhold generally for 24 to 48 hours, assess local and systemic causes. Immediately consider NEC as a differential, because it's the most important thing to be diagnosed, picked up early. Early pediatric surgery consult, and then according to the condition we'll take it up. So pharmacologically, to manage feed intolerance, 4 simple measures. Firstly being erythromycin, we have a 1-week regimen where it is 40 mg per kg per day, divided into 4 doses for 3 days, and then half the dose for the next 4 days at 20 mg per kg per day, divided into 4 doses. Domstal, of course, we can give at 0.25 mg per kg per dose every 8 hours. Metoclopramide is still under trials in newborn, but evidence is promising. And probiotics, like I mentioned, has a significant role in extreme preterms. Now coming into the NEC component. So by definition, it is an acute inflammatory injury of the distal and small as well as the proximal large intestine components, and it is the most common neonatal gastrointestinal emergency what we see. So pathology wise, it has segmental coagulative necrosis predominantly of the mucosa. Here and there evidences of focal hemorrhages as evidence of ischemic changes, the ischemia being the primary change. Intramural gas will be there, which manifesting as pneumatosis along with mucosal sloughing as well. Statistics wise, the incidence of NEC as a whole is seen in 1 to 2 per 1000 live births. More common amongst NICU with around 1 to 5% of all NICU admissions, term and preterm both combined, and 5 to 10% of VLBW babies as a whole. The etiology of NEC is of course multifactorial, with the greatest risk factor being prematurity. The average age of onset of NEC being between 30 to 32 weeks of corrected gestation. Other risk factors including maternal chorioamnitis, IUTR, maternal smoking and polycythemia. But a few risk factors which also reduce the risk of NEC being antenatal corticosteroids and empirical antibiotic usage. Genetics of NEC, TLR4 is the most accepted marker widely, and TLR4 mutations is the most common genetic cause of NEC, IL-18 being the second cause, although a much less incidence than TLR4. The pathogenesis wise, it is mainly because of an increased permeability of the intestinal epithelium, resulting in a decreased motility, thinning of the mucus layer, having a physiologically low level of IgA, and having a lack of regulatory adaptation. So coming to the inflammatory mediators, we have platelet activating factor, bacterial endotoxin, as well as TNF and nitric oxide as inflammatory mediators. Other mediators like COX-2, reactive oxygen species, free radical, TNF-alpha and IL-18 are also there, COX-2 being the predominant factor among these. Now, miscellaneous factors which have a role to play, less convincing evidence, of course, being the timing of feeds, volume of feeds, UAC catheterization specifically, especially if there are Doppler changes, presence of any hypoxic insults, PDA left untreated and low APGARs at birth, all of these having contributing factors. So a pathogenesis in the terms of a flow chart, prematurity being the main common factor, what we see resulting in decreased digestion absorption, formula feeding resulting in a carbohydrate and protein excess, ultimately resulting in a bacterial overgrowth. So this is the entire cell membrane what we are referring to. Whatever you see in red are the factors which favor the formation of NEC, namely hypoxia, anemia and gut barrier dysfunction, ultimately resulting in reactive oxygen species, free radical injury, translocation, infections resulting in NEC. Now focusing on the favoring factors which protect from NEC, which are highlighted in green, namely the presence of antioxidants, TLR4 inhibitors naturally, improving the barrier function which happens by probiotics, so these are combined here. Apart from that, following good feeding habits and exclusive breastfeeding and promoting breastfeeding to a larger degree. Now coming to the diagnosis, as far as NEC is concerned, early diagnosis favors a good outcome early. Clinical signs being, of course, apart from the GI components, focusing on other systems, having respiratory distress, presence of apnea, lethargy, temperature instability, irritability, hypertensive episodes and reduced perfusion. Abdominal signs, to give a specific mention, the presence of distension, gastric aspirates, vomiting and hematochezia are all favoring factors. So we can divide NEC into two courses broadly. Fulminant segment, where it rapidly progressive with the signs and symptoms which are consistent with NEC and sepsis. On the other side, you have slow paroxysmal presentation of the abdominal distension with the ileus and infection both. Like I mentioned initially, we have imaging studies available. The radiograph showing abnormal gas pattern consistent more or less with an ileus-like feature, with the presence of valvular edema, fixed position loops, maybe a presence of a mass, but pneumatosis intestinalis being a hallmark. Abdominal ultrasound is used to detect the intramural air and portal venous gas early, and it's a more sensitive marker. So this X-ray is a typical NEC X-ray, where if I'll zoom in to make it quite evident, you can just see it there. The portal venous gas is quite prominent, where the portal venous anatomy is well maintained, and pneumatosis intestinalis is well hallmarked here. Okay. So this is a typical X-ray as far as NEC is concerned. Similarly, little bit zoom in here, showing a bowel wall thickening. Similarly, portal venous gas being present on the ultrasound. Pneumatosis intestinalis on the ultrasound image. Another ultrasound image showing both free fluid as well as pneumatosis intestinalis both in the same window. Of course, more from a radiological perspective, zebra pattern or herringbone pattern is also considered as a hallmark feature of the intestine when you trace it. So due to the resemblance of the black and white stripes of the zebra to an extent of the fish herringbone, it is also called so. Now coming to the staging of NEC as per modified Bell staging. So broadly it's classified into 3 and each subtype has 2, so we have 6 subtypes. So stage 1 is suspected NEC. In suspected NEC you have temperature instability, apnea, bradycardic episodes along with lethargy, having abdominal signs of gastric retention, distension, emesis and heme positive stool. So the radiological signs being just dilation of the bowel loops with a mild iliac features. The treatment is keep the baby NP on antibiotics for 3 days, antibiotics covering both positive, negative as well as anaerobic spectrum. Stage 1B is suspected NEC with only difference being an extra abdominal sign of bloody stool. Occult blood positive is also included here. Now the difference between 1A and 1B is merely staging in the presence of blood in stool. Otherwise treatment, radiographic signs wise, treatment wise, everything else is the same. Now coming to stage 2A, clinical signs are the same. The gastric symptoms are the same, but you will have a absence of bowel sounds with or without abdominal tenderness. Radiographic signs wise, there will be a dilation of the intestines with ileus and onset of pneumatosis intestinalis. The treatment here is keep the baby nil per oral and antibiotic duration for 7 to 10 days covering the whole spectrum, especially anaerobic. 2B is where the serious level of the child increases. So the platelets and the gas will show features of metabolic acidosis and thrombocytopenia. Abdominal signs may show a mask-like feature or it might be pretty much asymptomatic. The radiograph will show same features as 2A with the additional presence of ascites. And the treatment wise, the baby is still kept nil per oral with antibiotics, but the duration is now increased to 14 days. Now coming to stage 3. Stage 3, again in the subclassification, we have extra clinical features of hypotension, bradycardia, severe apnea combined with respiratory and metabolic acidosis at the features of DIC and neutropenia. So the other issues what you deal with are signs of peritonitis, tenderness and distension. On top of all of this, you will continue to have ascites. The difference is management wise, we are already giving antibiotics for 14 days, but due to the features of shock, baby might require fluid bolus in 10 to 20 ml per kg increments. Of course, in extreme preterm, you cannot load beyond a particular point, so we might need to stop cardioprotective inotropes early, be it dopa or dobutamine as per the condition. Prefer to start at 10 mics and then step up as and when needed based on the pressure recordings. If very severe apneic episodes, it is always better to ventilate the baby, and paracentesis is indicated if there is a very strong feature of ascites only. Otherwise, we do recommend always for minimum intervention. Now, as far as stage 3B is concerned, pretty much it is the same. The hallmark feature only being the onset of pneumoperitoneum, and once a pneumoperitoneum onset has come, we have to go for a surgery. Surgical management is the only way. So, just a brief overview about the management of NEC. Management of NEC would be another slide in itself, another slideshow. But systemic wise, if we go, respiratory system wise, we supplement the oxygen, ensure that the gases are maintained well, titrate the ventilator settings accordingly, adequate ventilatory support. As far as the cardiovascular system is concerned, maintaining the blood pressures, fluid boluses if indicated. Due to the bleeding tendencies or anemic pictures, if needed, we can transfuse the blood products of PRBC as well as plasma. Acidosis correction is important. The first thing to do is always respond with the volume expansion. And bicarb correction we reserve only if there is a cardiac dysfunction and if the fluid resuscitation is insufficient. Electrolytes to be maintained because electrolyte imbalance is always one of the first early signs. And it's also a life-threatening emergency if it sets in early. Along with that, the glucose monitoring and maintenance of adequate GIR levels. Nutritionally, of course, GI feeds are withheld, nasogastric decompression is done, and feeds can be restarted once the CRP normalizes after ensuring adequate bowel rest. And infection control by covering the positive, negative, and anaerobic spectrum. Of course, antibiotic choice depends on protocol. Focusing purely on NEC, early starting of metronidazole helps. So it does cover the anaerobic spectrum quite well, and early starting is shown to result in a good outcome. Like I mentioned initially, ensuring platelets, PRBCs as well as FFP is transfused as indicated is good. It is also advisable not to overload the blood products, because overload of these blood products also result in increased inflammatory markers and increased expression of the TLR receptors. So as far as NEC is concerned, we only transfuse if specifically indicated. Routine transfusions we avoid. Now, as far as the renal management is concerned, urine output monitoring is very, very important. Oliguria will accompany hypotension as one of the initial signs, and urine output monitoring, I cannot stress enough on it. It is very important because renal shutdown is a very poor prognostic marker. Surgical management wise, it is always recommended to give an early cross consult to the pediatric surgeon, take their opinion early. Intervening as far as a laparotomy or a peritoneal drainage or resection or anastomosis as indicated, early intervention helps in giving a better outcome. As far as prevention of NEC is concerned, inducing GI maturation by antenatal corticosteroids helps. Exclusive breastfeeding by human breast milk, optimizing enteral feeds, probiotics specifically with bifidobacterium helps early, especially in extreme preterms. The role of polyunsaturated fatty acids in arginine supplementation is under study, but the results so far are promising, so supplementation of these do help. Along with that, the acid blockade and role of lactoferrin has also been shown to be proven, again though it is at a study level. Just a little bit about the recent advances. Specific biomarkers for gut injury include calprotectin, claudin, intestinal fatty acid binding protein, and inter-alpha inhibitor protein. Among these, calprotectin is a very sensitive marker and is now being studied as far as the prognostication is concerned. So with that, I have come to the end of this presentation. So basically, to summarize in a few words, feed intolerance is a common entity what we encounter in the NICU, and it's important to balance the rest of the gut as well as escalation of feeds both. NEC should always be kept in the back of the mind to ensure that we pick it up early, intervene early, and early intervention helps in an early resolution. And keeping in line with the recent times, recent advances are going on in this field. So the current line of management and thinking what we have towards NEC has changed. So with this background, thank you all for patiently listening up to the end, and hope you join for the next video as and when I upload it. Thank you.